Right, good afternoon, everyone. This is Debbie Nadzam Melnyk from VCSQI, and this is the May 24th meeting of VCSQI's Opioid Management Workgroup. So thanks to all of you who were able to join, and thank you for listening if you're listening to the recording later. For those of you who are new, you see on this first page the objectives of this work group. We're just trying to help everyone re-examine their opioid prescribing practices, if they prescribe opioids at all, and determine ways to improve them so as to minimize patients becoming addicted inadvertently. Today we're going to talk about a few different things. Whoops, I didn't mean to switch over to that. I did make a PowerPoint file for today just because I wanted to show some slides of our survey results that we launched in March. So we're just going to talk a little bit again about why we're doing this work. We're going to display the survey results, talk about some recommended actions everyone can take, and then again invite you all to tell your story. So let's see, I've got to close a couple screens here so I can manage this slideshow here. All right, so a couple weeks ago there was a pacing event, as they're called, that all of the practice transformation networks that are contracted with CMS are invited to attend. And so I pulled a few slides from that event because it was focused on, where are we all with helping our enrolled practitioners review their prescribing practices. So just a couple slides here, why this work is important. You see some alarming numbers here. You probably have all seen those, perhaps related to your state. Maybe you've seen this as well. So they're not pleasant numbers. The good news is that a lot of states are now taking action, and a lot of practitioners are examining, what they're doing and what they can change to minimize the use of opioids when not necessary, and help prevent addiction and prescriptions lying around that other people can get their hands on. 3 waves of the rise in opioid overdose deaths, and you see this is tracking from 1999 to 2016. I guess the 2017 numbers aren't quite yet available, although I don't expect that we would see any of these lines go down. Definitely the synthetic opioids are contributing significantly to overdose deaths. But the natural and semi-synthetic opioids are often those that begin with a prescription. So this is where all of us as prescribers can begin to hopefully make a dent. So in March, we asked all of our practices to consider taking a brief survey. It was a SurveyMonkey link. And I think many of the practices that don't even prescribe didn't take the survey. So we unfortunately can't say of those who answered the survey, 10% don't even prescribe. I think that's the bulk of our practices, though, do not prescribe. But 12 of you did complete the survey, so and 10 were considered complete responses. These are just straight downloads of the PowerPoint slides that SurveyMonkey creates. So going forward, there'll be a bar chart for the question and then the data. So here you can see of the 12 that answered, most, come on slide, move forward. Most said yes, they do. Here you see 75% of the 12 said yes, clinicians in their practice prescribe opioids. So 9 is kind of like the denominator going forward. Does your practice have an opioid prescribing protocol used by your clinicians? Only 7 answered this, 5 skipped. And of those 7, 4 said no, they do not have one. And 3 either do or are developing one. So you know, more than half, 4 out of 7, don't have a protocol that their clinicians are using. Do your prescribers use your state's prescription drug monitoring program when prescribing opioids? So there were a variety of, that could be checked, a variety of answers. 4 indicated they checked to see if the patient has other prescriptions. 2 said no, 1 didn't know. Oh, I didn't capture this other reason. This is good in that at least 4 of the 7 are checking to see if the patient had another prescription, but none of them said they were reporting a new prescription through the PMDP. Do your prescribers assess a patient's risk of addiction prior to prescribing an opioid? So again, of the 7, the good news here is that 5 said yes, they conduct an interview. So that's good. At least they're conducting an interview. Others are not doing anything. Hi, Stephanie and Angela. I see you've joined. We'll get to you shortly.
Hi.
Does your practice have prescribing restrictions for the number of opiate pills prescribed? 7 answered the question. 3 said no. 4 said yes. And the limits come through more on the next slide. So that's good. A limit is set. How many days or weeks of opiate pain meds do your prescribers typically prescribe? Of the 7 that answered, 3 prescribe as long as 14 days worth or 2 weeks worth. And only 3 others are prescribing less than a week or fewer. On average, how soon does your team follow up with patients who are receiving opiates? 7 answered it. 3 said, again, 2 weeks. 2 indicated it was 10 days or fewer, and 2 indicated they do no follow-up at all. Do your prescribers document in the medical record a signed opioid treatment agreement between the patient and prescriber? Of the 7 that answered, 4 said no. 1 is in the process of developing such a treatment agreement. So the majority here are not using any kind of treatment agreement. Do you have a patient and family education process to jointly determine how the patient can best manage pain and inform the patient of risks associated with opioids? Of the 7 who answered, oops, sorry about that. Most said they at least discuss with the patient and family the pain management options and risks. I've got some of my open windows in the way. 5 out of the 7 said that. Nobody provides written information of the respondents, and 2 indicated they do not have this discussion. Does your patient and family education material include information about how to safely dispose of unused opioids? Of the 7 who answered, 6 said no. This is important because medicine cabinets can be raided by friends, family members, and this is how addiction can either begin or be perpetuated by people who are looking for more opioids for their already existing addiction. Where do your clinicians primarily see patients? We were asking this mainly at one point to get into use of opioids following surgery. We did not. We chose to eliminate all those detailed questions for this follow-up survey, though, from the one we did in November, simply to keep it shorter for all of you. But you can see of those who answered, 6 are operating from their, I shouldn't use that word operating, are practicing from an outpatient clinic or office. Do you currently measure, track opioid prescribing practices with your patients? Of the 7 who answered, 5 said they're not tracking anything here. 1 said they are looking at follow-up, whether or not they are following patients after prescribing. 2 indicated they are looking at whether the patient is evaluated for their risk of addiction. Only question mentioned that we should have asked was whether or not naloxone is also being prescribed, which I think is a good question, particularly when you hear so much about the use of naloxone for reversing potential overdose death. So those is a quick summary of the small response rate that we got. The takeaways I thought were these. Most practices that prescribe opioids do not have a protocol. And this is probably a little more relevant when you've got a practice with more than one prescriber. Are they doing it the same way? Have they talked about, you know, what's better practice than not better practice? The state's prescription drug monitoring program is being used to at least check for whether other prescriptions have already been issued to these patients. Patients' risk is being assessed prior to prescribing, maybe not with a formal survey tool, but at least through an interview. Prescribing limits do exist, but most are giving at least 14 days worth with follow-up not before 2 weeks. Signed treatment agreement tends not to be used, but discussion about risks is usually done. Discussion about safe disposal is not usually done. There's minimal measurement by the respondents of the practices they're currently using to prescribe opioids, and the comment, maybe we should ask more about naloxone prescribing. So I just thought it might be of interest to those of you who have completed the survey and those who have not, to maybe think about how you would have answered these questions. So out of this, I mean, again, this is my own kind of thinking, but would invite discussion, and we're going to hear from 2 individuals from BKC Pain Specialists, one of the practices enrolled with us, about some of the activities that they have underway. But here's some things to think about. Review your state's laws. Many states have now passed new laws that require checking the prescription drug monitoring program, and these laws often have strong guidance related to dosage and duration limits. They're not trying to make this kind of cookbook medicine, but they're offering guidance as to what to think about, how to consider, and in some cases, yes, what the law is related to dosage and duration. Think about establishing a prescribing protocol that is in sync with the law's expectations. And what I've asterisked here is the CDC guideline for prescribing opioids to patients with chronic non-cancer pain. Consider non-opioid treatment regimens. More and more, there's evidence in the literature that shows how either other medications or other types of cognitive therapy, psychology, alternative medicine techniques may be even more beneficial than that initial opiate. Think about documenting the assessment of patient's risk. If you've conducted this through an interview, you might want to note it in the medical record. Consider a signed treatment agreement, particularly with chronic pain patients and those at high risk for addiction. If you're prescribing for an acute post-op, surgical situation, you still may want to know if the patient has a history of abuse, but asking them to sign a treatment agreement might be pushing this activity a little bit. There's some evidence out that patients are not understanding this, offended. So how you even present it can make all the difference with how a patient interprets what a signed treatment agreement means. And then also consider monitoring your practice's prescribing patterns to confirm compliance with the law and with best practices. So this slide also was from the National Pacing event we listened to, opportunities for positive change, treatment and reimbursement, medication-assisted treatment, evidence-based non-opioid treatment options, and then tools to prevent overprescribing, such as limits and checking the PDMPs, and certainly screening, education, and communication between the provider and the patient and/or family. So I'm going to pause here and ask our participating individuals from BKC Pain Specialists, Stephanie and Angela. If you'd like to jump in and tell us a little bit about what your practice is doing.
Hi. Can you hear
Hi.
us okay?
Yep.
Okay. I'm Stephanie. This is Angela.
Hi.
And I am the practice manager at BKC, and Angela helps run the compliance component, which is called SafeRx Solutions. Sorry, I always forget to add that. So I will let her go ahead and tell you about their program. They are contracted with us. We started with them, I think, back in September of last year, and they've done a lot of good with our company.
Stephanie, can you just tell us a little bit first about the practice and where you're located so everyone understands what state you're in?
Yeah, we are located in Marion, Ohio, and we have 2 physicians here. We run a pain management clinic, so we are prescribing a lot of opioids. We have been in practice since, I'm not good with math, but about 6 years now. We opened up this clinic, and our practice has grown. We have the 2 physicians, Dr. Katabi and Dr. Sanhaji. We have 3 nurse practitioners. We do procedures here of back injections, neck injections, joint injections, and a lot of the follow-up and prescribing narcotic medications. So we want to make sure that our patients are safe, that their families are safe, that they are following the protocol. We do have a signed agreement that they have to sign, a signed contract when they come into our practice. They are not supposed to be getting opioid medication from any other practice. We do use our state's ORS reporting system to see that they are getting medications where they're getting them from. And we can go back several years on that. We do that before we prescribe any prescriptions. That's done for every one of their appointments. SafeRx Solutions has helped with pill counts, and they do those randomly. We do regular drug testing, urine tests with our patients, or mouth swabs. We also meet with the patient. SafeRx Solutions meets with each and every patient at their follow-up appointments. And then recommendations are given to the doctor as to how much medication to prescribe, as far as the amount, like 2 weeks, like you were saying, or 1 month, 2 months, whichever.
Okay. All right, thank you. That helps us understand the environment now that Angela will tell us more about.
Yeah, so SafeRx Solutions, we call ourselves compliance medicine. I look to it as really being a new specialty in medicine, especially given the crisis and epidemic that we're facing, not just with opioids, but really with all controlled and illicit, drugs that are out on the streets. So what our team does, like Stephanie said, is we actually rent space in the office. We call ourselves partners, but we are our own practice within a practice. And our goal and our role is really to screen the patients. We have chemical dependency counselors, we have social workers, we have functional medicine nurses, we also have PAs, and then a board certified addictionologist on our team. And our team see every single one of those follow-up patients, and every patient is given a screen at every visit with a soap. I saw you mention there's several other screens that I can't remember all the names because I'm not as clinical as the rest of my team. But patients are screened at every visit, and then we do our homework essentially the night before, and we evaluate all the patients' previous urine drug screens. We look at their pill count history. We look at their ORS, the prescription reporting. We take a look at some of their family history, things like that. And then we do our visit prior to the nurse practitioner or the doctor walking in and seeing the patient, like Stephanie said. So based on the screen that we've done, the homework that we've done to evaluate the patient's risk, and then some of the questions that we asked on site, really we're starting to stratify patients' risks. So some patients have very minimal risk due to family history or due to the types of medication that they're on. They've passed pill counts, their drug screens have always been, you know, nice and compliant. But then we have those patients that are in the middle that they have tendencies, or they've admitted to taking their medication. And then we have some of our really big red flag patients who show signs of addiction, failed pill counts. And instead of, Dr. Katabi's whole philosophy on why he brought our team in is, in the past, when patients would violate their contract, they were often released from the practice. And Dr. Katabi felt like, as a physician who's been prescribing medications that are highly addictive to patients, when I cut them off, he said, I'm sort of contributing to the problem that we see out there. And then some of these patients could turn to illicits and sometimes heroin if they're not able to get their pain meds. So rather than kick the patient out or discharge a patient from the practice, our team will start to manage that patient's care at a higher level. We do our specialty visits on Fridays, where we offer that medication-assisted treatment, Suboxone, Vivitrol. We also just offer counseling, not just for addiction and not just for compliance, but we offer counseling for trauma, depression, anxiety, smoking cessation, weight management, all things that play a role in chronic pain. So, our goal is, that less patients are going to end up on the streets turning to illicits, and more patients are going to learn how to take their medication safely. And we all work together as a team, and it's been, I feel, a really big benefit to this community. But we are our own practice. We do our own billing based on the level of visit that we see, and our providers supervise some of the counselors and such. So that's a little bit about our program. If you have questions, I'm open to answering. I'm sure I missed some things. The protocols are set and they are followed, and it's nice because it takes a little bit of the bad cop off of the doctor, and it puts it on us to say, we're here to protect you and protect the provider and protect the community.
And so you're called Safe RX Solutions? Is that the name of the practice? Can you hear me okay?
Did you get all that?
Yes, but can you hear me? Can you hear me? Did I go on mute somehow?
We're not hearing everything that you're saying.
Okay. I'm wondering, I just wanted you to confirm the name of your practice. Can't hear me. Does anyone have any questions? Can anyone else hear me?
I'm just getting bits and pieces of your words.
Okay, look at the chat box.
I think so.
Eddie, can you hear me?
We still can't hear you.
We can't hear.
I can hear you, Debbie.
Ivan, can you hear me?
Yeah.
All right, you might want to turn your volume up if you can't hear me. So I'm curious though. Can you hear me now?
Let me try dialing in so that you can hear us and we can hear you.
Okay, we can hear you. Ivan, do you have any questions? I don't know if they can hear you or not.
Enter their meeting ID followed by the pound or hash sign.
Can you hear me, Stephanie?
Pound. Otherwise, just press pound to continue.
I can hear you, Ivan. I'm sorry. I don't know why the audio suddenly.
Participants in the meeting. This meeting is being recorded.
Is that better for me?
Okay, now we can hear you.
All right. So one of the questions I had for both of you, I guess, is how do you approach, we've talked about this on a previous call, bringing up a article that was in the Cleveland Plain Dealer. I don't know if you saw it all in Ohio, Southern Ohio, but that patients can be offended when they're asked to sign a treatment agreement. They don't understand this. They feel like they're not trusted. How do you approach the whole idea of what that treatment agreement means and why it's important?
Well, our agreement is it's pretty detailed, and so far we have not really had any patients that have been offended by it. We send out the packet of information prior to their first appointment, and as fill it out, bring it in with them. So when they come in, they've already read that, and if it's not signed, they have the opportunity to ask us questions about it. It is reviewed at their first appointment to make sure they do understand why we have them sign that.
And what tends to be the best explanation that most patients understand with why it's necessary?
I think it's mainly just protection for them and for the doctor prescribing them, and they seem to understand that.
Yeah, our counseling team often says to patients, you know, if you've turned on the TV or opened a newspaper anytime this week, you're certainly reading or have heard about this thing called the opioid epidemic. And if, you know, we're going to feel comfortable prescribing medications that, you know, have the potential for addiction and they are controlled medications, this is just part of the changing times. And I think you guys have had a contract probably since day one.
Yes, ever since we opened this clinic, we've had a contract.
And it evolves. You know, it just evolved recently when SaferRx Solutions joined the team because our expectations for pill counts, because we monitor all controlled medications on our side, because often with addiction, there's cross addiction, or sometimes, you know, patients may be abusing a benzo and there could be some diversion going on with, you know, an opioid. And the only way to find out is to monitor and count all controlled medications. So we had to incorporate some of that in the contract, and we get a little pushback on that, but it's typically only from the patients who may be not following the rules.
Right.
So they bring the pill, they're supposed to bring their bottles in to their appointments?
Not to every visit. We do it randomly, and I say randomly with quotations because if we pill counted every patient every day, we'd have to have a team of 20. But we pill count based on risk, based on the number of controlled medications that they're taking. You know, on the ORS report, there's now the NAR-X score. So if, you know, you have a score above a certain amount, you're at an increased risk of an accidental overdose. So if you're taking a benzo and an opioid, you're going to expect to be randomly pill counted, not just at your visit. We will call on a Tuesday at 2 p.m. and we have some parameters that we offer if the patient works or lives out of town. They go to their pharmacy and do a remote pill count. We also have a HIPAA compliant way for them to text some pictures, but we try to reserve that for only certain patients that are stuck and you know, don't have transportation, but you'd have to have a smartphone for that.
Okay, would you be willing to share your treatment agreement?
Sure, give me a chance to go get that.
I mean, if you could email it to me and you don't mind us sending it out to people, or
Sure,
post
that would be fine. I can do that.
Great, thank you. And again, Angela, in terms of the practice, SaferRx Solutions, is that something that is beyond, you know, where Stephanie's located?
Yeah, we're actually getting ready to expand. We have an office in Columbus that has been wanting our services for a few months, but because we had to go through the credentialing process and our protocols and stuff, they've been vetted by board certified addictionologists and in compliance with state guidelines, and we evolve our protocols as really the laws change, but we are ready to expand. We just had to finish that really, really fabulous process of contracting and credentialing with all the payers that we're fortunate enough to see. So yeah, we do have growth plans in the future, and we're open to meeting with any practices that would be interested in using our services. I just ask that, if anybody's interested, to just be a little bit patient with us, because, when we come in to an office, we bring a team with us. It's depending on the volume, we have a couple chemical dependency counselors as well as a supervising provider. So finding the right people is really the biggest challenge that I have, because we want to make sure that we find the right fit for your practice.
Sure. So you are not a pain management practice?
Oh, no, I'm sorry, we are not. I didn't hear the beginning. No, we do,
right.
Essentially, I call it compliance medicine, but we offer
Right.
addiction and recovery services, as well as the other services.
Right. No, I just wanted to restate that too, so that we all understand.
Yes.
All right.
Yes.
Well,
we do have some input and feedback from some retired pain management physicians, but they're not contracted employees. They helped us with design our protocols.
very interesting. Anyone else have this sort of resource in your state or your community?
No,
I mean,
to my knowledge, no one else offers this.
okay. Well, this is very interesting. I'd love for you guys to work with me or Ivan to set up a story about this that we can share even more broadly.
Sure.
Thanks so much, both of you, Stephanie and Angela, and we'll look for that practice treatment agreement that you so graciously agreed we could share with the other practices.
Sure, I will get that email to Ivan.
Great, thank you. Trying
That sounds good, thanks.
to stay true to a half hour. We are just past 30 minutes. This again is a slide, the one that's showing now from the national presentation a couple weeks ago. Just something to think about. So I'll just end with, tell us your story to improve prescribing practices. The template, which I've sent around before, I'll just show it again here. This is the coming out of the national work group. I think this is on the VCSQI website. I can send it around again with the minutes from today and the link to the recording. It works very easily. This is really just the practice template to actually complete it. And see, you would check VCSQI. You would say what the story is, probably a single practice. You'd type in your name and such, and there's a lot of, open text boxes. But you actually submit it by doing it online. This is just one to give people a sense of, what this template involves. So we'd encourage you to, you can work with Ivan or email me directly, and I'll talk you through it. And hopefully find some stories out of our large group of enrollees that we can share, not only with all of you within the, our group, but outside as well. Okay, so we meet again. Let me just see if we really kind of covered everything on the agenda. I think the only other thing more quickly now, with establishing this work group for a position on opioid prescribing with cardiothoracic surgery patients. And then again, a reminder about the stories. Our next meeting is scheduled for June 28th, 1 to 2 p.m. If you've got topics you'd like to discuss and hear more about, please send me an email in reply to the minutes, which I'll get out to all of you probably by tomorrow. Anything else anyone wants to add? All right. Thank you all again. Thanks again, Stephanie and Angela, and have a good rest of the day.
Have a good day. Thank you.
Bye-bye.
Thank you, Debbie.